The other thing is sort of this risk of exposure and potentially leading to psychosis or other adverse effects. There is some data out there about cannabis potentially being a factor that might trigger a psychotic break in a vulnerable individual. Those are typically individuals who've had a family history of psychosis or have other risk factors. And this points to the importance of proper medical and psychological screening for these therapeutic modalities. There are certainly short lists of conditions that are currently screened out in the literature. And I would say that these would be very conservative screen out procedures because obviously the research is being done. We don't want to have harms. We want to show safety. And eventually what may happen is some of those absolute contraindications in research studies might be loosened into relative contraindications in real world applications. For the time being, we're making sure that people have a tolerance for rises in blood pressure and heart rate. Ketamine and MDMA known to physiologically cause this. Classic psychedelics might inadvertently cause this through profound emotional, nervous system arousal states that might also just cause the physiology to engage that way. So people with a history of active and severe coronary artery disease, untreated hypertension, history of stroke, and other issues where that kind of stress to the cardiovascular system might incur risk would be screened out. And psychologically, some of the more common ruled out conditions in the research involving psychedelics have been personal or family history of psychosis, active psychosis, in some cases, suicidal ideation, although a history of suicidal ideation has not been a screen out factor. Many people with chronic treatment-resistant depression or chronic treatment-resistant PTSD or even substance use disorder certainly have had suicidal ideation or attempts, but it would be more extreme or active suicidal ideation with a plan. So there's instruments like the CSSRS that have been used to quantify to some degree a person's suicidal risk to the point that they may be screened out. Other risk factors or other conditions that have been screened out include borderline personality disorder, which is really a term that describes a lot of emotional lability, ups and downs, without a lot of capacity or resilience to self-regulate, and some difficulties with perceptual biases towards Black and white thinking, desperation. Sometimes there's chronic suicidality or self-harm associated. And, the character structure, personality structure, if seen as coping adaptations to past psychological injuries, may just not be coherent enough, at least for preliminary research with psychedelics, to include people with this diagnosis. Although certainly in my experience in MDMA research and even in ketamine therapy, individuals with some borderline traits are not screened out. And I've seen people do well in therapy with these approaches. So bipolar disorder is generally screened out in psilocybin and MDMA therapy, whereas with ketamine, there is actually some research evidence for effectiveness of ketamine in treating bipolar type 1. So those are some of the general, and it's not an exhaustive list, certainly. There's other conditions I haven't mentioned that would also be important things to look at, whether that be physically, physiologically, or with respect to a person's stability from a mental health perspective, where we want to just make sure we're not introducing undue risk by creating conditions such that that person is in a non-ordinary state of consciousness that might physiologically or psychologically actually cause harm. And so far, the safety data has been excellent. Phase 3 publications, a phase 3 publication with MDMA was published in Nature Medicine last year with the first round of phase 3 data, which included 90 participants who completed the study and the study measures. And there were no suicides. There was very robust safety data that came out of that research in keeping with previous safety data from earlier phases of clinical investigation. Now, so you might be thinking about, well, but what if you take LSD and jump off a bridge? We're talking about, in this context here, a controlled clinical environment, right? So again, coming back to set and setting, if a person is in an uncontrolled environment, is in an environment where there are risk factors posed by the environment, and they're disoriented because of being under the effects of a substance that can cause a level of disorientation, certainly there's risk. As there is with other substances like alcohol, for example, and other medications where it's advised to not get behind the wheel of a motorized vehicle when under the effects, for example. So really making sure, again, that set and setting are attended to as part of safety considerations is really, really important here. So I'm not commenting with broad strokes on the safety in general in all environments outside of a regulated or controlled clinical setting, but more so just in a therapeutic context and controlled setting where we're actually able to really make the environment safe and conducive.
This mini lecture is part of Numinus' Introduction to Psychedelics, which is a free course where we explore the world of psychedelic medicines and their potential as therapeutic tools. Check out the link in the description for more info.